All right, excellent. Potential conflicts. So the objectives, I want to try to keep this practical. As sort of Russ went over and I'll fly, I already took out about 8 slides because I had actually sent my slide deck to Gil beforehand. So there was a good deal of overlap. We'll review the emerging evidence regarding the currently available therapeutics for UC, some of the newer data, and I think really discuss selection of treatment in patients with new onset IBD. I think is clinically relevant. So as sort of Russ pointed out, and I'm more simple, it's really, this is what I tell my patients, and this is what I tell fellows or people that work with me. Nowadays we're trying to treat smarter, predict who will have aggressive disease, treat earlier, treat them when the disease is still inflammatory before any of the complications that are irreversible can take hold. Again, talking about treating deeper, at least discussing, thinking about potentially aiming for mucosal healing, at least mucosal improvement, and again, treating to target with the patient, discuss the goal that you think is best for them, work towards that. And again, treat more effectively. It's hard for me to get up here and not talk about proactive TDM, so I sort of worked that into this talk as well. And again, this is really what we're looking towards, this sort of personalized medicine. The oncologists are better. When I was a resident at Yale, Steph Targan came and spoke to us about this, said we were 10 years away. The gray hair tells you he was a little bit short because we're probably now maybe 10 or 20 years away still. But again, it's risk stratifying and then choosing the best medication for the patient. For UC, what about risk prognostication? We're not particularly good at it. There's very few factors associated with the low colectomy risk, although the risk of colectomy in patients with UC is down about 10 to 15%. But again, limited, distal disease, mild endoscopic disease, the higher colectomy risk. I think the biggest risk factor is severe endoscopic lesions. Those patients I treat more aggressively, even if they don't particularly appear to be that sick as far as symptoms are concerned. And again, the theory to treat earlier with effective therapy is to stop the disease progression, stop the complications from occurring, and again, improve quality of life, change the natural history. But again, you balance this by putting, all patients on therapies that, again, some may have some toxicity. Regardless, all the medications we have now are quite expensive. This is just a slide from Crohn's. I should make another slide for UC, but it basically shows these are different trials, and it shows that the disease duration, the shorter the disease duration, the higher the number of patients that entered remission. You can see there when patients have had the disease 9, 10 years, their remission rates are in the low 30s to 40s, where if they're earlier in the disease course, they're upwards in the 60s to 70s. Again, this is just reiterating what Rush showed for Crohn's. This is UC. This is also the IOIBD. The goals are both clinical remission based on, in this case, diarrhea and rectal bleeding, as well as endoscopic healing. And they say 0 or total look normal endoscopically is the optimal target, but 1 should be the sort of minimum, and assessment should be performed 3 to 6 months after therapy starting in UC. I think, to me, it depends really on what your drug is and how quickly you think it's going to act and what you're going to do when you find something. Again, whatever the goals you decide with the patient, it's important to see that you hit that goal or didn't hit the goal. And again, adjust treatment, optimize treatment. To me, it makes sense. You're going to optimize whatever drug they're on. That's that's no-brainer. Optimize whatever drug they're on. I think the tougher situation is, what do you do when you haven't hit the goal? Are you going to change classes? And is the patient going to want to change classes? So the list of drugs we have to treat with ulcerative colitis is growing. You can see here, this is the list. Most are approved. Cyclosporin, steroids not approved. 5-ASAs for mild to moderate disease is standard of care. What I would say with 5-ASAs is make sure you optimize it, right? You want to make sure, studies have shown that topical therapy, rectal therapy actually works better than oral therapy in patients with distal disease, and the combination of oral and topical is actually better than either one alone, both in distal disease as well as in patients with more extensive disease. So I really optimize that before moving on. Steroids, we know induce but do not maintain remission. Whenever I see a patient, I can almost always tell them, you've already been on the most dangerous drug that we use, that's corticosteroids, greatest risk of serious infection, as well as even mortality. The thiopurine, 6-MP, and azathioprine really have fallen out of favor in the treatment of ulcerative colitis, certainly for induction. They don't work quickly, but even maintenance, they've fallen a little bit out of favor. Typically, when you're using these, you're using them in conjunction with an anti-TNF to decrease immunogenicity and boost levels. That being said, I still have plenty of patients that are doing well on azathioprine and have been so for some time if it works. These patients do well over long periods of time. You guys know about the anti-TNFs. We'll touch on vedolizumab, tofa. I'm not going to touch on cyclosporin too much. That's, again, used to induce remission in those patients with severe hospitalized UC, failing IV steroids. And again, you need something to transition to. It's like prednisone, like the corticosteroids. You should, as soon as you start it, you should be having a conversation about what we're going to do to get you off of this. So budesonide MMX, being kind, I'll say, is modestly effective for induction of remission in mild to moderate UC. The benefit here is the side effect profile. It's much less toxic than systemic corticosteroids. There's a high first pass metabolism in the liver, so only about 10% reaches the systemic circulation. But you can see the primary endpoint, you got about 5.5% over placebo with a p-value of 0.49. So it works for, I think, for those with very mild disease. And again, it's a steroid, so think about what you're going to be doing next to get them off of it. Methotrexate, now there's 2 studies that really show it is not effective for maintaining steroid-free remission in UC. One was a European study, and the most recent one by Hans was a U.S. study. Again, the lines couldn't be closer together, showing that it is ineffective in the treatment of ulcerative colitis. There we go. Vedolizumab, I am not going to show you all the phase 3 trials of these things. I think it gets boring. I think you won't remember. This is a selective adhesion molecule inhibitor. This one specifically targets alpha-4 beta-7. It's currently IV, 0.26, and typically every 8 weeks. Now approved 5 years ago. It's effective to treat moderate to severe IBD, including ulcerative colitis. I think it's a better maintenance agent than it is an induction agent, particularly for Crohn's disease. In anti-TNF naive UC, it actually does tend to work more quickly. It appears safe in the UC trials, really no different than placebo as far as adverse events are concerned. There is, just to be aware, one case of PML that's been discussed. It was important to note this was also an undiagnosed HIV patient, and HIV patients are clearly at risk for PML. So again, that's more likely what it was related to and not the drug itself. Tofacitinib is a Janus kinase inhibitor, the first one we have approved for UC, an oral small molecule. This was approved a little over a year ago. This is effective for both induction and maintenance of remission in moderate to severe UC. This was the first drug we had where, given at the higher dose, the 10 milligrams twice a day, actually appeared to be effective in those patients already exposed to TNF. Every other study, those TNF-exposed patients never do nearly as well as those anti-TNF naive patients. There are some safety issues. Zoster shingles, we were sort of aware of that, particularly in the 10 milligram twice a day group. That was really the serious infection. Again, based on its mechanism of action, people will say maybe there's a higher risk of lymphoma and non-melanoma skin cancers. Lipid elevations tend to go up both with HDL and LDL, so less than like 3% of patients will actually require a cholesterol medication. I think the biggest issue, and the one we know little about, is this risk of venous thrombosis, pulmonary embolus. There was a statement that came out by the FDA that basically said almost nothing, just there was some increased risk. But it's clear it was a post-marketing study done in rheumatoid arthritis, patients over 50 years old who had at least one cardiovascular risk factor, and they were following patients on the 10 milligrams twice a day, which is not approved for RA, versus 5 milligrams versus a TNF group. And the quote down there was from the EMA, which basically, and again, this is all they said. There was no primary data that we're waiting for, but there did appear to be a 5-fold increased risk of PEs on the twice-a-day arm compared with the TNF arm, and a 3-fold risk compared to previous studies with TOFA. And there was actually a higher rate of all-cause mortality in the twice-a-day group. So more to come, and I think it'd be important to see what this is, the actual data, but it is important to think about in our patients with UC, particularly those that are sick enough, because we know they're at a higher risk for DVTs and PEs. It does work quickly. I put this up because I was like a middle author on it, but it was mostly Steve's work. It does show that you can see these curves separating as early as 3 days when they looked at patient-reported outcomes, both in stool frequency and rectal bleeding. There you go, 3 days, red arrows. Biosimilars, there are now 6 approved for the treatment of adult IBD. Here they are. I'm going to do a whole talk on these later, so we're going to move on. I think the big question is, how do we choose the right agent? It's never clear, right? There often isn't a clear choice, more thoughtful discussion. 2 patients, I chose pretty easy ones, I think. A 45-year-old male, recent history of ankylosing spondylitis, now diagnosed with UC after presenting with 6 to 7 bloody bowel movements a day. 55-year-old male with multiple comorbidities, recent onset of left-sided UC, failing oral and topical 5-ASAs with about 4 to 5 bloody bowel movements a day, right? Patients you may see in the office. Again, what would be the ultimate? The ultimate would be knowing ahead of time which patient is going to respond to which mechanism, right? That's the ultimate. The companies are trying to do it. No one has really successfully done it yet. The best hope is you put them on the drug and that they respond. Again, you'll see this slide. Russ showed it. I updated it a little bit for UC specifically. There was a UC success trial, this sort of stepchild of the SONIC trial, not nearly as well done or designed, but showed combination therapy with infliximab and azathioprine outperformed either drug on monotherapy. The European trial that showed for severe steroid refractory UC, infliximab is as effective as cyclosporin or vice versa. That's the best data. Head-to-head data is what we need. Russ showed you the data on the one study that was presented both at ECHO and DDW that really it looked like for moderate to severe ulcerative colitis, vedolizumab outperformed adalimumab without dose optimization, and it didn't actually appear to make a difference as far as getting patients off of steroid or steroid-free clinical remission, which I think is the most important. There was no difference there. I'm going to point out you can't compare across trials, which is why I'm not going to show you that slide that has all phase 3 on the same, because it's different patients. What can you say? That the different drugs have been approved by the FDA and by the AMA. So clearly they work for whatever their indication was. And there was a systematic review and network meta-analysis. Again, as Russ said, I've done some, meta-analysis. These network meta-analysis, I'll leave that to Sid Singh, because it showed what I sort of think about in the clinic, and I think which makes sense. I'll show it to you. It really suggested that for new onset disease, infliximab and vedolizumab appear to be the most effective first-line agent for UC. Again, take it with a grain of salt. Whatever you put into a meta-analysis, I like to say sometimes garbage in, garbage out, but if Sid did it, I trust him. And again, this is what it showed. The higher the sucra ranking, the better. And you can see here infliximab and adalimumab were sort of furthest to the right, the highest odds ratio, which is what you're looking for. So what about in the clinic? How do you decide what the agent is? There's disease-specific factors you're going to take into account. Severity of disease. Do they have extraintestinal manifestations? Do they have associated conditions like psoriasis, rheumatoid arthritis? That's going to affect what agent. Certainly patient-specific factors, particularly what are their comorbidities, and obviously you need to take into account what their thoughts are on what agent they want to go on. You need patient buy-in before you start a medication. Medication-specific factors, again, what are the two most important things to me? I would imagine to you and the patients. Efficacy and safety, right? Those, I think, rise to the top as being the most important. The other stuff we talk about, rapidity of onset, durability of remission, I think immunogenicity is huge as well. Cost, mostly cost to the patient. We should be worrying more about cost to the medical, but we don't. Physician comfort, physicians have to be comfortable with what drug they're putting agents on. They have to know how to use it. Insurers or payers probably have, unfortunately, a bigger role than we'd like in deciding what therapies we use, but we'll leave them out of it for now. So associated conditions, most of these here for UC tend to favor, anti-TNF, right? The anti-TNF treats the other drugs. For RA, tofa is also approved, so that could be something to consider in a patient who happens to have UC and RA. So back to the patients, 45-year-old male with a history of angst-spawn with extensive UC, presenting with 6 to 7 bloody bowel movements a day. What would I choose? Me personally, I would do optimized monotherapy with infliximab using proactive TDM over combination therapy with infliximab and azathioprine over adalimumab, over vedo or tofa. The guy with multiple medical problems failing 5-ASA, this is a patient, I'm going to try to go with the safety profile, typically go with vedolizumab over the other agents. In practice, I try to think of, right now, if a patient has more moderate disease, to me, using an effective agent like vedo, which has a very good safety profile, if they respond, great. They're on an agent now that, best we know, is very safe. If they fail, then I'm going to go with an agent that potentially has more effectiveness, but potentially more potential adverse events. So I think this is important. Whatever agent you choose, optimize it. There's nothing worse than seeing a patient who's now failed 6 biologics and none of them were optimized. So the first agent you choose, if it's an effective agent, it works best. Many studies have shown TNF-exposed patients do not respond as well as those patients who are TNF naive. There's a high rate of secondary loss of response, particularly to the anti-TNF agents. The risk of developing anti-drug antibodies is not insignificant. We know they're associated with loss of response and infusion reactions. I think TDM is underutilized, particularly proactive TDM. And if you're not doing proactive TDM, which you all should be, combination therapy with infliximab should be used and should probably be considered with the other anti-TNF agents as well. What is proactive TDM? It's basically dosing to an adequate drug concentration. It's not new, right? You do it with cyclosporin, I do it with Vanc, do it with Gent. This is not a new concept. High drug with some results in toxicity, has not been documented with the anti-TNFs. Low drug concentration, if they're not taking it, it's not working. And with biologics, it leads to immunogenicity and again, loss of response. We looked at our patients that had gotten proactive TDM dosed to a window of 5 to 10 compared to the remainder of patients from our IBD center. And you can see there, very few of the patients that were getting proactive TDM that attained a trough concentration of 5 lost response compared to those patients that were getting standard of care, which was empiric dose escalation, often at 10 mg per kg, or reactive testing. More recently, in combination with PEN, we showed that proactive, when compared to reactive testing, actually, besides improving length of drug, decreased surgeries, hospitalizations, antibody formations, and serious infusion reactions. We most recently published data similar with adalimumab, that it improves length of time on adalimumab, and Russ sort of hinted at this. Even with SONIC, which is the best data we have for combo therapy, when they did a reanalysis, it actually turns out it really appears to be the amount of drug in the system. If you look there on the right, unfairly, I circled combination therapy in the first quartile, which is basically undetectable levels. And if you compare that to the fourth quartile, which is infliximab concentrations of greater than 5, that orangey color is basically what I would term optimized monotherapy with infliximab, right? So it's the amount of drug in the system, not necessarily the combo therapy that matters. So take-home points, optimized mesalamine. Don't forget your topical therapies. Budesonide, modestly effective for mild to moderate UC. Methotrexate, not effective for UC. Infliximab and vedolizumab appear to be the best first-line agents for UC. And optimize your treatment. Assess disease severity. Predict who's going to have a worse outcome. Treat patients earlier with effective therapy. The first agent you use is the most effective, so please optimize it. And again, I think proactive TDM with the anti-TNF therapies really does optimize outcomes, and I would certainly consider that as well.